Hello, my name is Mia Kivipelto. I'm professor in clinical geriatrics at Karolinska Institute. I'm also the director for research and development for Theme Aging, Karolinska University Hospital, working also part-time at the University of Eastern Finland and Imperial College London. And it's my great pleasure to be here today and talk about the effect of nutrition and ketosis on cognitive health. Here are first my disclosures and grant support related to the academic studies which I'm leading. And during my presentation, I will first discuss can dementia and Alzheimer's disease be prevented, and here I will especially focus on the role of diet and nutritional factors. Then I will move to the multi-domain interventions and the exciting journey we have started when we are moving from the finger trial to worldwide fingers, and after that, the potential role of ketosis and the future directions. How much dementia can be prevented? We do not know yet exact answer for that, but the most recent estimates are saying that around 40% of dementia is related to these 12 modifiable risk factors listed here. And I think it's very nice that this list has been growing during the last years, and there are several vascular lifestyle-related factors, as you can see, diabetes, high blood pressure and obesity at midlife, physical inactivity and smoking, just to say a few examples. If we turn the discussion from risk factors to protective factors, here we have, of course, the healthy, balanced diet and in general, active lifestyle. It's important to keep in mind that the evidence level for these risk factors is still varying. For some of those, like the vascular risk factors, is already quite strong, and for others, more studies are still needed. I also think that this prevention approach is very important globally, and it has been getting a lot of attention. WHO has launched the risk reduction guidelines for cognitive decline and dementia 2019. My team was very much involved when we went through the evidence for the risk factors and protective factors in a very systematic way. And I think this is an important document. It gives an evidence base for the implementation activities in many countries. What do we aim to prevent then? Dementia is the final kind of endpoint of the long process that may start 20 or 30 years before we can do the dementia diagnosis. And there are, of course, these Alzheimer and other neurodegenerative pathologies and vascular pathology. And more now we are moving to the earlier interventions, starting the interventions and preventions at risk persons. And here we can do it in different ways, focusing on biomarkers. This can be done especially at the memory clinic settings, or we can also focus on modifiable risk factors as listed here. It's also good to keep in mind that among older persons, dementia is nearly always mixed. There are both Alzheimer and often vascular pathology, and actually the pure AD pathology is there only in 10 to 30% of cases. And given these complex, heterogeneous, multifactorial etiology of late onset dementia and Alzheimer's disease, I believe that the multi-domain prevention strategies are needed to get a real optimal preventive effect, modifying, targeting several risk factors and mechanisms simultaneously. How can we then move from this knowledge about risk factors to clinical trials and sustainable implementations? As said, I believe that the multi-domain intervention is really key, and here especially diet and nutrition-based interventions are very important. At the same time, we have learned that one size does not fit all. We still need to learn more about the mechanistic foundation so that we can tailor the interventions to different at-risk profiles. I have been leading the FINGER trial. It was the first large-scale randomized control trial showing that it is possible to prevent cognitive decline among at-risk persons from general population using these multi-domain lifestyle-based interventions. We selected the patients or the persons in this case using the dementia risk score, which we have earlier developed, meaning that they had at least some modifiable risk factors present. Totally 1,260 persons, age range 60 to 77 years from general population. And the multi-domain intervention, it was like one hand and five fingers. Healthy, balanced nutrition was one key factor here. Exercise, cognitive training, social activities, and taking care of all vascular and metabolic risk factors for 2 years, compared to so-called regular health advice group or control group. The intervention was 2 years. Now we are ready with the 5 and 7 year follow-ups, and we hope to start the 10-year follow-up later this year. I think it's very important to learn also more about the long-term effects. Here you can see a photo for the finger intervention. The participants really enjoyed, especially the group training, where they got some social interaction and extra motivation as well. Adherence was high, dropout rate only 12% after 2 years, and luckily no serious adverse events. Here you can see the main results for cognition. Global cognition improved 25% more in the multi-domain lifestyle-based intervention, and there were also clear improvements in all pre-specified cognitive subdomains. Executive function, how we can do planning or multitasking, 83% more improvement. Processing speed, how quickly we can do different activities, 150% more improvement, and memory, 40% more improvement. And the control group had 30% increased risk of cognitive decline in global cognition after 2 years. Interestingly, ApoE for carriers, ApoE is the most important genetic risk factor for dementia. ApoE for carriers got clear beneficial effect of this multi-domain lifestyle intervention. And I think it's very optimistic finding because we can't modify or change our genes, but with this type of lifestyle-based intervention, we may try to reduce the risk. On top of the clear benefits on cognition, there were also several other health effects of this intervention. 30% lower risk of functional decline, improvement in mobility, better health-related quality of life, and interestingly, the risk of other chronic diseases was significantly reduced. The risk of multimorbidity was 60% lower. And related to that, there was lower risk of hospitalization and even clear health economic benefits. So this same type of intervention seems to have the effects on brain health and total health on individual level, but it may also have broad effects on societal level if we can delay the onset of dementia. We have been looking more closely how people can follow this advice, and here is an advice for the dietary intervention adherence score in relation to the intervention participation. Here you can see the score, what were the goals achieved, the dietary advice, what we gave to the participants. And it seems that these persons who came to the interventions more than 5 times were able to keep the healthy dietary habits even after 24 months. You can see these upper lines here. Those persons who had bit lower adherence, who came to us less than 5 times, they were able to improve the diet for 12 months. But as you can see here, there was a little bit less optimal diet after 2 years. And the control group, even though they got this general advice, they were not able to change the dietary habits. So we can say, based on these findings, that older people can change dietary habits even on long term, but they need some guidelines and support in order to do these more long-lasting changes. Finger intervention has been getting a lot of interest globally, and we started and launched the Worldwide Fingers Network 2017 to support how we can test, optimize, and adapt the finger model in different settings and in different cultures. One important aim here is also to harmonize the protocol so that we can more easily compare the results after the trials, and also share experiences and data so that we can really use all the lessons learned. And I'm very happy that now, 2021, we are having more than 40 countries from all continents who are part of the Worldwide Fingers Network. I think we are learning a lot from these different trials and planning. Of course, COVID pandemic has been giving a lot of methodological challenges, and we have been just trying to handle this and have a common approach, how to take into account these delays and these effects. And one important concept here is e-fingers. Can we use more digital tools, e-health tools, to support in the interventions and in the implementation? Dietary patterns is of course very important feature if we are thinking Worldwide Fingers, because the dietary habits are quite different in different cultures. If we are thinking the healthy dietary patterns, there are several. For example, the Mediterranean diet, which has been studied quite a lot, or the Nordic diet, which we used in the finger trial, MIND diet and DASH diet. All of those have similar kind of components and features. For example, encouraging fruits, vegetables, whole grain, low-fat dairy, fish, and unsaturated fats and olive oil. And try to limit saturated fats, red meat, ultra-processed food, and added sugar. A lot of this evidence comes from observational studies, but there are also some randomized control trials, for example, suggesting that Mediterranean diet has effects on cognition as well, on top of the other beneficial health effects. A very low carb, high fat, ketogenic diet or ketogenic drink has emerged as a promising alternative after recent pilot studies. What could be the way linking a ketogenic diet and ketosis to brain health? One important aspect is, of course, the brain energy. Brain is only around 2% of the mass of the whole body, but it actually consumes around 20% of the energy. So really a lot of energy is needed. And we know that ketones are the brain's main alternative fuel to glucose, and ketones supply around 60% of brain energy after a week's fasting. We have evidence from PET studies that brain uptake of ketones is proportional to peripheral levels, and the slopes of this relation is similar in Alzheimer's disease, Alzheimer patient, and healthy young adults. And this brain energy rescue theory has emerged as a therapeutical concept for neurodegenerative disorders of aging. And here it's especially important to keep in mind that ketone metabolism seems to be preserved in Alzheimer's disease, where we know that glucose metabolism is declining and there is clear glucose metabolism. So this kind of opens a clear window for this type of interventions. There are also other possible pathways. Epigenetic signaling, these results are mainly from experimental studies, but they are suggesting that ketone beta-hydroxybutyrate is an epigenetic signaling molecule and could affect inflammation, oxidative stress, and even increase BDNF. What are then the ketogenic strategies we could use? This so-called ketogenic diet is studied already quite a lot, very low carb, high fat diet. But there are also the fasting, it could be time restricted feeding, and these non-carbo windows. Or ketogenic medium chain triglycerides, MCT supplement or drinks. including mainly C8 and C10, or the combinations, for example, MCT supplement and this type of time-restricted feeding. One question that is still a bit open is if this carbohydrate restriction is needed to really mimic the effect of a ketogenic diet, and also what are the long-term effects. Here you can see results from these recent pilot studies and trials with ketogenic diet in patients with subjective cognitive impairment, mild cognitive impairment, or mild Alzheimer's disease. The duration of the studies have varied between 6 weeks to 6 months, and the sample size around 20 patients to up to a little bit more than 100 patients. And there have been, interestingly, improvements in memory and even some other cognitive domains, and even biomarkers like microbiome and Alzheimer biomarkers, amyloid and tau in CSF have been improved, as well as some interesting findings in the PET scans. What do we then know about the possibility of MCT supplement with normal diet to improve cognition in MCI and AD? Here the trials have so far yielded a bit mixed results. There have been improved cognition in some studies as listed here for patients with mild or moderate AD and MCI for some cognitive subdomains. There have been also studies showing no clear difference in cognition comparing this supplement with placebo. In this study listed here, ketosis was actually lower than expected, which could be one reason for these negative findings. We can also again ask the question, if we combine this supplement with other type of ketogenic strategy, would that give even better results? Our recent findings from the coffee and cream study suggested that ketosis from MCT was higher within 16-hour non-carb window, suggesting that this might indeed be the case. I would like to show some more results from the recent BENEFIC study with the ketogenic drink and the question if it can improve cognition in mild cognitive impairment. This was an oral nutritional supplement containing medium chain triglycerides, and these results are based on 82 completers, persons with MCI, including both amnestic and non-amnestic type of MCI. The length of the study was 6 months, and the active group received this oral supplement 2 servings per day, and the placebo group placebo product 2 servings per day, and the formulation and organoleptic properties of both interventions were similar. The results showed in the PET study that there was indeed increased brain ketone uptake in MCI after 6 months, and also sustained blood ketone response after 6 months. 4 cognitive tests, free and acute recall, verbal fluency, Boston naming test, and trade making test showed improved results for this group receiving this ketogenic drink. And interestingly, there were improvements in 3 main cognitive domains: episodic memory, executive function, and language. And higher plasma or brain ketones correlated positively with changes on these 4 cognitive tests. So these findings, both when it comes to efficacy, safety, and tolerability, suggest further testing of this type of ketogenic supplement on the longer-term trials, and to see if it can affect the progression to Alzheimer's disease. A few findings from our coffee and cream study, which I mentioned earlier. This was a 6-arm crossover study in 15 healthy older adults who were keeping the ordinary diet. We were monitoring biomarkers after intake of coffee and cream with different test oils. And here you can see the main results. There were clear differences, so that the persons receiving C8 supplement and who were fasting had higher ketose levels compared to the persons who received C8 with glucose, again suggesting that this carb window and fasting may have an importance here and need to be studied further. Final question which I would like to mention here, if it matters if the ketosis is continuous or could we use intermittent ketosis as well? Ketogenic diet has been mainly studied in the epilepsy field and for weight loss, and here the arguments could be that this continuous ketosis is needed to avoid the seizures or helping to keeping on track if it comes to the weight loss as an example. However, adaptation of the ketogenic diet on the cognitive field, here we could think that the intermittent ketosis could be a better alternative. Also because there may be these other non-ketosis pathways, there could be higher flexibility, also avoiding involuntary weight loss, which is an issue, especially in Alzheimer patients. And also potentially fewer hyper responses in biomarkers and maybe easier to have the compliance in longer term. We hope to test this hypothesis further in the Cognifood study, which we aim to start this year at Karolinska Institute and Hospital, and testing two different diets. The first diet is this intermittent ketogenic low carb high fat diet. And then the second diet is high carb, low fat diet, which is in line with the official dietary guidelines. Very exciting to see what will be the results of this type of study. So, summing up then, what do we know about the possibilities to prevent dementia and Alzheimer's disease? Can we really prevent it? I would say yes, at least part of cases can be prevented or at least delayed, and here healthy balanced diet may have a key role. How can we do that? Multi-domain interventions, as mentioned, I think really is important if we want to have an optimal preventive way. And here we have results from the finger trial that this model is feasible and effective, and now is further adapted and tested within the worldwide fingers context. The potential role of ketosis and ketogenic supplement is very interesting, and we have some preliminary findings about the feasibility and even some effects on cognition and biomarkers. And I think this is a promising area to be further tested in longer-term studies. And for the future, I'm thinking a lot the combinations. First, the precision prevention, tailoring the interventions for specific at-risk profiles, and the combination, finger type of healthy lifestyle combined with different type of nutrition-based interventions and even pharma products when needed. This is how I would visualize it. What is the future of AD prevention and treatment? I don't think there will be one single pill solving the whole complex disorder, but it is indeed a cocktail where we are moving from the complexity to more personalized medicine, having the healthy diet and nutrition, and adding different type of intervention and supplements and medications when needed. I want to thank all my group for the work I have presented here, and then I want to thank you for listening. Thank you so much.